Afternoon. We'll go ahead and we're running a few minutes behind, so we'll get started as folks head out the back door. Thank you for being here. Last session of Sages and all. My name is Mac Harmon, and I'm co-chair of this session. We're going to talk about adolescent surgery. They look like adults but aren't the same. And hopefully what we'll do is after each talk, if there's a question or two, we can do that, and then at the end, hopefully there'll be some time for more group discussion if that would be of interest to people. So it's my pleasure to introduce the chair of this session, Gretchen Purcell Jackson, to get us started talking about anatomy, physiology, and most importantly, psychology of adolescence.
All right, thanks very much. Okay, welcome all to the adolescent surgery session. We're running a few minutes late and we have a lot of great speakers, and I've only actually allocated myself a few minutes to talk about these topics. Oops, I actually forgot to say, both as moderators and as a speaker, neither of us have anything to disclose. In 10 minutes, I'm not going to be able to cover the broad topic of adolescent anatomy, physiology, and psychology, but I wanted to spend just a few minutes touching on several adolescent topics that warrant consideration when these folks present for surgery. Now, I wouldn't be a good pediatric practitioner without having a talk to remind you that children are not small adults, and likewise, adolescents shouldn't be thought of as large children. Although they may look like adults, adolescents who are undergoing surgery and experiencing illness have unique issues that must be considered. One of the important issues for adolescents is changes in body composition, especially in light of the increased prevalence of adolescent obesity. And as a practitioner who cares for adolescent patients, I think it's a good idea to have an understanding of what changes are occurring in these people and what is considered normal. Now, the rate of change in height during the pubertal growth spurt is at its highest outside of the period of infancy. And interestingly, height growth is greatest during the spring and summer months. So if you're looking at growth in a child, especially a teen, you always want to look at an interval of about 6 to 12 months. Male and female teenagers are roughly the same height when they begin puberty, but males emerge 13 centimeters taller on average, and this is primarily due to a 2-year lag of boys behind girls in growth as well as other parts of development. Weight gain velocity increases and peaks during the adolescent growth spurt, but the onset of weight gain and the peak rate of growth are highly variable, so you're going to see teens growing at different times. The weight that they're going to gain during puberty, it counts for approximately 50% of their ideal adult body weight. Now, during childhood, boys and girls have relatively equal proportions of lean body mass, skeletal mass, and body fat in the category of all things that are unfair. At the end of puberty, teenage boys have 1.5 times more lean body mass and skeletal mass than female teenagers, but female teenagers have acquired twice as much fat mass compared with male teens. With regard to body composition, I think one of the biggest challenges that I face as someone who operates on adolescents is that I often find myself being the first person to tell a teenager and their family that the patient is overweight. And this usually happens in the context of discussing operative risks. As you saw on the previous slide, height and weight both increase rapidly during adolescence, and individual rates of change may vary. When confronted with a difficult discussion, I find using the Center for Disease Control growth chart showing body mass index for age is a useful tool to discuss weight relative to height objectively. As you all know, BMIs between 85 and 95 percentiles are in children, we use the term risk for overweight, and over the 95th percentile is considered overweight. Now, this is not a judgment, it's a clinical diagnosis, and it's a risk factor for surgical complications. And while it's not my job as a surgeon to primarily manage a patient's weight unless he or she is considering a bariatric procedure, I do find that preoperative discussions are very valuable teaching moments when patients and families are open to very broad suggestions regarding their health, even when you're doing an operation that has absolutely nothing to do with their weight. And I've had personal great success in referring overweight teens that I've encountered in surgery to our very successful pediatric weight management program at Vanderbilt, a very successful medical weight management program for children. And many times, again, I was the first person to actually discuss weight as a problem in teenagers who were morbidly obese. From a medical legal standpoint, one of the biggest issues to consider before surgery in a teenage patient is, could that patient possibly be pregnant? So the normal age for menarche ranges from 9 to 15 years, usually occurring about 3.3 years after the growth spurt and about 2 years after breast budding. The age at which young women begin menstrual cycles is dependent on a large number of factors: race, socioeconomic status, heredity, nutrition, and culture. African American girls are generally starting their periods the earliest, followed by Mexican American and Caucasian girls afterwards. Interestingly, these girls begin periods later when they live at higher altitudes, in rural areas, or they grow up in larger families. Now, body composition also influences the age at which girls are starting their menstrual periods, and there's controversy about whether there is a necessary amount of adipose mass that's needed before this happens. One alarming trend is that the age at which girls are starting to have periods has gradually decreased in the last century, and some people think that this is due to the increase in adolescent obesity, although the trend has slowed in the past few decades as obesity has markedly increased. So preoperative pregnancy testing in adolescents is very controversial. And while the decision to test is something that's often addressed by the anesthesiologist, I think it's important for surgeons to be familiar with the issues. As you all know, anesthetic and other agents during surgery can cause birth defects, interrupt pregnancy, or cause preterm labor. And pregnancy status for adolescents may not be known. Teens may be very reluctant to discuss the possibility of pregnancy, especially in front of their parents. So there have been a number of studies that have looked at preoperative pregnancy testing in adolescents, and this slide shows the results of some of the larger studies. Azam and colleagues conducted a 2-year study of mandatory pregnancy testing in all adolescents who presented to the Cardinal Glennon Children's Hospital in St. Louis University. They studied 412 adolescent patients who ranged from 10 to 20 years and tested those folks. The overall incidence of positive tests was 1.2%. Only 5 patients tested positive and were actually pregnant, and they were all over 15 years old. Malvia and colleagues studied all adolescent female patients who were seen at the C.S. Mott Children's Hospital at the University of Michigan who were undergoing elective outpatient surgery over a 2-year period. Of 525 cases, 17 patients refused testing. Of the 508 patients that they tested, ranging in age from 10 to 17 years, all pregnancy tests were negative except one that was a question negative. That patient actually denied the possibility that they could be pregnant, and in follow-up testing, they were actually not pregnant. And finally, Pierre and colleagues studied patients presenting to a same-day surgery unit in Boston. They tested 801 patients ranging in age from 12 to 21 years. 6 of the girls had positive pregnancy tests. 4 were found to actually be pregnant, so that's a rate of just less than 0.5%. There were 2 false positive tests that were associated with ovarian failure and elevated gonadotropins, and of the 4 who tested positive, only 2 admitted to sexual activity and only 1 admitted to the possibility of being pregnant. So, given that, these studies do show very low event rates, but they do detect unexpected pregnancies. So when should you test? Well, again, this is a controversial topic. The evidence doesn't conclusively support testing everyone, and I think the bottom line is that if you have to make this decision, you have to use your own clinical judgment. Your institution may have specific policies that dictate what you have to do. Documenting a thorough history about the onset of menses, the date of last menstrual period, sexual activity, use of protection, and the possibility of pregnancy is always a good practice. And in all cases, getting consent for testing and giving the families the option to refuse is preferred. What's most important is that you plan for how you're going to handle that positive test or the refusal of testing, especially if that refusal comes from a parent. All right, I promised at the business meeting today that to get people to come to this session that I would explain teenagers, so here we go. The next couple slides, I'm going to talk a little bit about psychosocial development in adolescence. First, like other children's, adolescents are a homogeneous group, and they display a wide variability in biological, psychosocial, and emotional growth. Each adolescent is going to respond to life's challenges, including illness, in a very unique and personal way. The transition from childhood to adulthood doesn't occur as a continuous, uniform process. Both biological, social, as well as emotionally and intellectual growth may occur completely asynchronously. And further, periods of growth may be accented by periods of regression. And while many people describe adolescence as a time when individuals are extremely unstable and labile, most adolescents actually cope with this developmental process well. So there are 3 phases that adolescent development is divided into, and I'm going to describe each of them with their clinical implications. Early adolescent psychosocial development is prompted by the rapid physical changes that are occurring with the onset of puberty. And these physical changes encourage, first of all, attention to self, and they initiate the so-called adolescent struggle for independence. The onset of puberty occurs about 1 to 2 years earlier in girls than it does in boys, and so the psychosocial and emotional changes are also going to be occurring earlier in girls. So this phase of development, usually occurring from 10 to 13 years, is going to be characterized by a shift from a dependence on parents to independent behavior. As with all children, it's extremely important with young adolescents that you direct your conversation to the patient rather than to the parent, because they will, especially in this age range, really want to express their own ideas and concerns. The rapid physical changes that are brought about by puberty result in preoccupation with body image in young adolescents, and this is a time when they're having the questioning of, am I normal? As with all patients, it's especially important at this age to recognize that adolescents may be extremely self-conscious about their developing bodies. And I can say that I had open heart surgery when I was 10 years old, and I remember it being incredibly stressful to have dozens of people coming in and examining you and to be partially undressed at times. So I think you need to be very sensitive to this, and you need to be sensitive to the fact that when illnesses set teenagers apart from what is a normal adolescent. Early adolescence is a time when young teenagers have increased dependence on their peers and their friends for opinions and support, and patients at this age may especially benefit from meeting other patients at the same stage of development with a similar illness. Finally, early adolescence is a time when teenagers begin to develop the cognitive ability to think abstractly, and this allows you to begin discussing long-term consequences of their choices, lifestyle, and behaviors. But keep in mind, again, development is going to vary widely across individuals. Middle adolescence, which generally spans the age from 14 to 17 years, is a time when teens have experienced most of their physical changes of puberty, and thus there's less preoccupation with body image and increased acceptance of oneself. However, this is a time that if a teenager is outside of normal for some reason, that discomfort with body image can be worsened and lead to things such as eating disorders. The powerful role of peer groups and peer pressure is most apparent during this time of middle adolescence, when teenagers try to conform to peer values, code, and dress, and teenagers focus their attention on participation in peer groups. On the good side, that's going to be clubs, student government, team sports, and on the bad side, that can be gangs. For children who are ill at this time, peer support groups can be especially useful. And finally, during middle adolescence, teens develop an enhanced sense of individuality, and they have increased openness and often feelings of omnipotence and immortality, which can lead to risky behaviors. Accidents, suicides, pregnancies, and drug abuse are increasingly prevalent in this particular age group. Finally, late adolescence is that final stage of identity development and separation from the parents. And if everything's gone well with the earlier phases with a supportive family and a peer group, the adolescent will be well on their way to handling the tasks and the responsibilities of adulthood. If not, emotional problems such as depression or suicidal tendencies may emerge as the young adult is confronted with increased independence and increased responsibilities. Body image concerns at this stage are usually limited unless, of course, the adults have experienced an illness which sets him or her apart from what is normal. For most, but not all individuals, this is a time of reduced restlessness and increased integration. And because the adolescent at this point has usually clearly separated herself from their parents and families, he or she may actually be more open to hearing the parents' or family's opinions or accepting their values at this time. It's also a time when adolescents have the greater ability to delay gratification, make independent decisions, think through ideas, and articulate their ideas in words, as well as the enhanced ability to compromise. And all of these skills can make coping with an illness easier, but it's important to remember that injury and illness may delay development, so your patients may have issues and concerns from some of the earlier stages if they have been chronically ill. So that is a very quick tour of important issues in adolescent anatomy, physiology, and psychology. So I'll take any questions.
Thank you, Gretchen. Are there any comments or questions after her introduction, setting the stage for the other speakers?